Thank you very much, Dr. Del Maestro, for inviting me to speak. So definitely happy to be here. And unfortunately, it seems that lately I've had a few Friday meetings, but I've joined at least one, and they're great meetings. So I look forward to joining more. So I will be talking about AI and image-based biomarkers for prediction modeling in neuro-oncology. So these are some disclosures, probably not so relevant here, but just in case. And what I'm going to do is that most people here probably haven't been to my other talks, so it's okay. So I will start by discussing some things about image analysis, computerized image analysis, and AI in general. And then we will change the focus and talk about um, imaging applications focused on neuro-oncology, and really with an angle to neurosurgery. So even though some of the content is generic, I think there's opportunity to discuss some of these things in more specific detail that I think would be relevant based on what I've seen, both in terms of this group and also to neurosurgical practice in general. So this is just more as a warm up, but we all think about AI. AI is a hype word, but we have to remember a lot of things we talk about are machine learning. Deep learning, which is really responsible for a lot of the excitement that we see, is really a subfield of machine learning. And these are subfields within the AI itself that has many fields, as you can imagine: natural language processing, robotics, so on and so forth. So sometimes I'd like to give that as a perspective, because sometimes, for example, in the imaging community, people think AI is just one thing. And really, we are talking about just part of that subfield. As in a neurosurgical specialty, of course, you're very well aware of at least one other subfield, which is robotics. And in the long run, how the two are merged could result in some very exciting opportunities. Now, the talk is going to be I will be discussing a lot image-based biomarkers, but I think these are very relevant, and I hope at the end of the talk it will be clear why. So when we talk about image-based biomarkers, so we are really interested in extracting quantitative features from medical images. I do think it is important to separate the processes, though. And if you really want to separate the process, one is the actual image analysis, computerized image analysis, which does not even have to be AI, right? It depends on the application. And then there's the construction of a prediction model, which is very relevant clinically because it gives us a certain outcome of interest in a way that we could potentially apply it in clinical practice. And then these are really the two things. And the latter, AI, is definitely the tool that, at least in the future, is likely going to play a great role in. Going back to computerized image analysis, and also to merge some of what's in the literature, if you read the literature, computerized image analysis has been around for many years, right? And in the literature, let's say if you go in the last 10 years, you see a lot of terms like texture, you see radiomic analyses, and sometimes I feel there is some confusion, and it's important to clarify that. So both in terms of analysis of the literature, but also for you to be able to, understand the literature and design projects that might be of interest to you. What we are really trying to do is really get these quantitative features that we may not be utilizing or underutilizing currently in our evaluation of images. Now, let's talk about texture, because there's a whole body of literature talking about texture. First, definitions vary. I'm taking one definition here that I've shown that I think is a good one, and it's really, a lot of this is in context of oncology, but it has been defined as objective quantitative assessment of tumor heterogeneity based on the analysis of distribution, relationship of pixel or voxel gray levels in the image. And so, that is a good definition used in a lot of imaging literature. And really, in more practical terms, what are we trying to extract? If you look at, let's take a CT scan. We already have some quantitative metrics. For example, on any kind of PACS viewer, we can take a region of interest, ROI. We will get a density measurement, and we'll get a standard deviation. These are first order statistical features that are, of course, part of the texture. But in texture, you're trying to capture more. You're going beyond those basics. You can look at things like skewness, kurtosis, and then actually going to much more complex features like second order statistical features, waveforms, so on and so forth, things that we are not capturing currently with the tools that we have. because there's increasing body of evidence demonstrating that these features can have an association with outcomes of interest clinically. In a simple way to think these are all complex terms, but what is the simple way? I always like to show this diagram. I don't know if you can see my arrows. Sometimes people can, sometimes they can't. But if you look at these two squares, they have small boxes within of different colors. And both of these have the same average, and they have the same standard deviation. But I think anyone here just has to look and they know they're not identical because there are greater associations between these in terms of neighboring arrangement that are not captured in these basic measurements. Really, in the simplest term, that's what you're trying to capture. One is in the case of tumors, we're trying to capture tumor heterogeneity quantitatively in ways that go far beyond an average or standard deviation. So this is really what all of this is geared for. Now, radiomics is a term that we are more and more using, and we actually try to avoid using texture. It was introduced in the literature in 2012 and defined as high throughput extraction of large amounts of image features from radiographic images. In 2016, this definition was expanded as conversion of images to higher dimensional data and subsequent mining of these data for improving clinical decision support. So I sort of like this because it has a much more broad definition to it, and it allows us to really look forward as the technology changes, and naturally then the definitions would have to adapt. This is like an umbrella term. Now, when one thinks of texture versus radiomic, it's important to know, although in the radiology literature, for example, texture is used very loosely to refer to sometimes all of these quantitative features. In the computer science and computer vision literature, a lot of times texture has a very specific definition. We don't have to get into that, and I don't even want to get into what definition is right or wrong. And in that sense, I like radiomics because it encompasses all of these and avoids getting into the nitty-gritty about terminology. So what you're really trying to do is capture these features and use them for decision support. Now, the other thing is that, sometimes we talk about these things, and in the age of AI, we think that these are all AI, but that's not the case. And it is important to know these because you see that this has implications if you're designing experiments. This group is well aware of, by the way, in terms of feasibility, a possibility of overfitting, there are implications, and one needs to know the different ways. So when we do image analysis, we are extracting quantitative features. It could be non-AI based, and indeed, most of what are called texture studies, that's what they are. They're non-AI based, most of the traditional radiomics. Or they could be AI based. Now, if you go back, at least in some of the computer science literature, one may divide the non-AI based features as handcrafted radiomic features. Handcrafted features are essentially, you can think of them in two ways. One is that for the most part, they're defined by a pre-designed mathematical formula. And the other key is the design prior to the experiment. So experts come, you can discuss whether it's a secondary statistical feature or a waveform feature. These are designed before the experiment, and then they're applied to see if there's an association with an outcome. Now, we can also do AI-based image analysis, especially with deep learning. Very powerful image analysis tools are available now. The difference with these is that those features extracted, if you want to refer to them as deep radiomic features, those are learned. So they're not pre-designed by experts. It's the opposite. So you run a whole set, you give it depends, you can do a supervised. Right now, most of them are supervised. And then you extract, and these are learned from data. So that's the broad categories that are different. And it is good to be aware of these. Just to give you a summary, handcrafted quantitative features can be broad. We talked about, you can have intensity-based statistical features, histogram-based features, volume histogram-based features, morphologic features, local intensity features, and texture matrix-based features. And each of these have a whole range within them. Now, as you see, this table goes towards the definition used in computer science or in the image biomarker standardization initiative, which is a good thing if you want to get familiar, good documents. And here, texture matrix-based features have a very specific meaning. And that's what I was getting to you. This is why, in a way, we avoid using texture. In a lot of radiology literature, especially earlier, you see this texture used loosely, in computer science, texture is just one subset of these other major categories of quantitative features. But bottom line, these are mostly, remember, mathematical formulas and expert design, typically prior to the experiment. So if we can summarize up to now, we can extract quantitative features using computerized image analysis. I would suggest radiomics is a good general umbrella term. By the way, whether it's AI-based or not, and as you saw, one way of maybe referring to is handcrafted radiomic features versus deep radiomic features. And then remember that you can do these via non-AI approaches and AI-based approaches. Now, theoretically, what I'd like to say is that we would imagine that if we had infinite data, chances are that deep radiomic features might be sufficient. But you have to be aware right now that evidence does not exist. This could be because most of our images are small, most medical data sets tend to be much smaller. And as I will discuss shortly, there is a certain advantage of handcrafted features and classic machine learning methods when using small data sets. But just keep that in mind. That has to be empirically proven, and that has not been proven. For example, right now for our image analysis pipelines, we now run everything as a standard through both. So we have, handcrafted radiomic feature extraction pipeline that is then integrated to predict with machine learning, which is going to be my next section. And we have one which deep learning or AI is used immediately on the images to actually extract features. Now, this goes to the second part. So that's the image analysis and feature extraction part. The next part is the prediction modeling. And if you think, at least in the clinical domain, that's what has the potential for translation. Me saying that there's an association with GLCM with certain outcome, I mean, that doesn't translate into clinical practice. We need sensitivity, specificities, negative predictive values, that kind of thing. So this is where the prediction modeling comes through. And again, another source of confusion. I hope after this talk will no longer be an issue. So now, while you can do things with statistics, clearly machine learning is a game changer here. Because machine learning approaches can be used to predict, make very complex associations. Of course, in the future, the other advantage is theoretically, unlike a classic software, a machine learning algorithm has the potential to improve with time, which is truly revolutionary. Although you should keep in mind that at least right now, we do not have a regulatory framework that allows that. So even if you have an AI algorithm, it is trained using AI, but it will not adapt in real life. And there's reasons for that, right? Because then you need to have a check. There's a question of stability. What if the algorithm goes off? So keep that in mind. But machine learning, definitely a game changer. And by the way, you can apply machine learning to any data. It could be an image extracted feature. It could be blood tests. It could be pathology, molecular, anything. So you can, by that logic, you can use machine learning either on handcrafted radiomic features, or if you're doing deep learning, of course, you can combine the two, because it is not that you can't do image analysis with classic approaches, but it's really not that effective. So practical purposes, we don't run an SVM for image analysis now, right? It's just not robust enough. So with deep learning, one thing that's interesting is you can design an architecture that analyzes the image and does the prediction modeling. And now you can see why there can be confusion, because there are these different processes. But think of these separate pathways. And I would say, at least in the foreseeable future, if you have a project that involves imaging or probably any other data, consider these two, because both of these are relevant in the foreseeable future until we are in those massive data sets where the answer of superiority versus complementarity, which is the other alternative, is settled. Now, I will get into applications soon, but just a little bit of discussion of machine learning approaches. So with machine learning, some divide machine learning into more conventional or classic, and then the deep neural networks. Examples of classic are support vectors, tree-based approaches like random forests, and of course, deep neural, and actually the artificial neural networks, which by themselves are a classic method. But if you use them to make complex architectures, these are the basic blocks of deep learning. And the closest you come to an agreed upon definition of deep learning is where you have 3 or more hidden networks. Then it becomes a deep neural network. Now, why is this relevant for medical? So again, if you have an infinite data set, clearly deep neural networks are very powerful at making complex associations, and they'll be superior. But you have to be very careful. If you have a very small data set, actually a deep neural network may not even work. Like you may get a completely off, non-reliable result, could be overfit, because these naturally, they're complex, they're good at detecting and making complex associations, but they require large amounts of input data. And in that sense, classic machine learning approaches have an advantage. Sometimes and this is the reason why in a lot of small studies you see them, because they tend to better sometimes predict the performance of a model when you have a small data set. And of course, right now, we are in the thing that a lot of our current experiments, we are planning for larger sets, and we're doing this simultaneously. And that's, depending on the task, there are sweet spots for what number. It hasn't been established. But usually you'd at least need in the hundreds to successfully apply deep neural network for most of the image analysis tasks, even basic ones like segmentation. And so that's the reason it's good to be familiar. Again, if you're designing an experiment, I would not write the classic machine learning approaches off, because for a small data set, and you're, especially in the clinical setting, you're aware that that is one of our limitations, that sometimes people who are in the machine learning world don't think of off the bat. We don't have infinite data. It's not like images of a cat where you can just go over the net and accumulate millions, right? And so it's good to know these until we're in the point where we have large sets. And of course, this also points to that in the long run, we do want to harmonize and make data accessible so we can do those large experiments, right? Those are going to be key in the future if we want to apply these technologies, especially deep learning, successfully. And really, this is what we're trying to get, is you do this analysis to get something that is of interest for our patients, whether it's a predictive molecular endpoint, probability of an outcome, so on and so forth. And just to give you an idea before I go into specific applications, obviously the exciting part is always the algorithm and prediction. But again, this would be obvious to this group that, in reality, more than 50%, frequently still 70, sometimes 80% of our effort is really in the data curation or preparation part of the process. And this is why I think if you think of future successful AI, we have to not only think of, the algorithms and the potentials, but also upgrading our informatics infrastructure to share data, to effectively process data, to have high quality data. If you don't do these things will stay in the lab, because those are key. And right now, I would say that too much of our effort is going into this. You want to tip that balance ideally. If you put the right infrastructure, you can tip that balance. And this is something, I think, an investment that will be worthwhile. And some of that is actually basic informatics infrastructure. It's not AI, but it'll be key to successful AI implementation in real life setting. So now for the second part of the talk, let's talk about some radiomic and machine learning applications for brain tumor evaluation. And just to let you know off the bat, currently, the majority of these, although there are studies coming with deep learning, many of these use what I mentioned, those more handcrafted approaches, and frequently classic machine learning for the reason we discussed, small data sets and so on and so forth. So when you look at the brain tumors, there are actually a number of publications, and they're constantly increasing. This invited review was in 2000. It was just not even a year ago, and things have already increased, but it gives you an idea. So one category of interest is, of course, to use these approaches for histologic classification or differentiation of tumor types. This could be glioma grades, GBM versus METs, metastatic subtypes. And as you see, all of these tasks, there are one or multiple publications looking at these. And at least some of these tasks are clearly clinically relevant. And one of the caveats you have to be aware of, and one of the challenges in general of these approaches, because these are mostly unlimited data sets, small numbers, the main question that still remains is generalizability, meaning that, okay, I develop an algorithm and ensure performance. What's the likelihood that this, if, let's say, implemented in a completely independent institution, is going to work? And that's the question, and perhaps some of the skepticism, and it's a correct one if you understand the technology. But if you look at all the papers and the fact that everyone is still able to get quite a decent performance is that it does suggest that there is something there that we're not using. So when we do our qualitative assessment, clearly there are things here that could, if you want, augment as an assistant our evaluation of the images in order to help better guide patient care. And where we push that, I'll get to in a bit in the later section when we talk about pathology, biopsy, but there's clearly potential there. But now's the time to start doing the bigger studies and also the multi-institutional. Of course, one of the challenges is also quality data. Remember, you know, the algorithms are as good as the information that goes into. And all of you are aware that there's still a lot of, you know, there's a lot of things missing, like medical data, the way we have it, just what's in the charts, there are errors, all the information is not there. And it, at an even higher level, and I think we have discussed that before with Dr. Del Maestro, one of the interesting things is even if you think of our gold standard, which is pathology, yes, pathology is very important, but pathology is not absolute. To someone outside medicine, they may think, oh yeah, that's a diagnosis, but everybody here probably knows that depending on which part of a tumor you biopsy, you may get a different result. And in some ways, when we design these, let's say the next generation, you almost want to include that in there to find the optimal method, because sometimes you have to realize that actually what we consider gold standard has its own deficits, and we need to take that into account, right? So we don't want to be too absolutist. And this is going to be the evolution of the way we look at things and even the way we look at gold standards, which is interesting. Now, we talked about tumor classifications. There are fewer studies, but definitely very relevant, something that I think we are going to embark on a bit more seriously here, of tumor response or distinction of tumor recurrence from pseudoprogression, right? This continues to be a challenging, it's an area that's a deficit. It's funny, some people see AI as a threat. I actually see AI as potentially a blessing for our specialty in terms of increasing our role and relevance. So if the machine can help me be more accurate, I don't see how that's a threat. I think that increases our usefulness and value in the spectrum, which is ultimately the patient care pathway. That's what matters. It's not even a question of imaging. It's a question of diagnosis, right? So this is one area, there are few studies again suggesting that AI can help. And this is an area that clear of interest and would have a clear impact because, you know, this continues to be a challenge. And sometimes you get delayed treatments. And also sometimes we give treatments with potential toxicity. And if you can predict a high likelihood of failure of response, then you can avoid those. So these could have significant benefits. Also, I want to sometimes, again, medical personnel are more familiar with this, but to people outside of medicine, they have to remember that most of our treatments are statistical. They're probabilistic, right? Very few things in biology are 100%. So we should not expect 100% performance. Indeed, if you tell me something has 100% performance, I'll have to question it. Is that even realistic? We want something that has sufficient predictive value that can guide management reasonably, just the way we do now or better. And if we focus on that aspect, I think we will put realistic goals and then will give us results that can actually be useful rather than setting unrealistic goals that then are almost bound to fail before you even do the experiment. And, you know, so we talked about histologic classification. There's a whole host of studies, again, because this data is widely available, looking at imaging features, you know, doing quite good performance in predicting various characteristics. And by the way, this is not always a surprise. Even if you take at semantic features, so I didn't talk about semantic versus agnostic, but if you think the features that we relate to, like as a radiologist that I may describe in the report, you know, necrosis, even if you look at semantic features, they have an association with some of these things. So it's not a complete surprise that if you do a higher level quantitative analysis, you can predict this. But there's clearly something there that could be of value. And then there's a lot on survival. I mean, this is, again, a lot of things right now are by sample convenience, right? So it's, you can get survival, so a lot of studies. I mean, I'm more interested in how can we relate that to changing patients' management? But, you know, a number of studies use these approaches to predict survivals defined in different ways. And of course, you can tailor, right? So one of the interesting things is, I think this is where domain knowledge is important. And this is why I truly like, I think the real success here like in many things, but probably more even here, is to be multidisciplinary. If you're in the OR and always struggling, you will know some of those questions, and then these can be applied. And by working together, then we can see what imaging might help you, and that is very relevant, right? For example, if I'm not the one trying to separate a tumor from a certain structure, or having to deal with it in real life, it won't be on my radar unless I'm attending tumor boards or working with neurosurgeons to do that. And I think this is where the multidisciplinary collaboration helps us try to leverage this technology to address things that can have a real impact. By the way, some of these things might not even sound that cool to someone who's outside the field, but to someone who's inside the field and knows there's a challenge, just like discrimination of pseudoprogression from recurrence on imaging, there are going to be things in the OR that you struggle with. And then the question is, can we apply this technology, leverage imaging better to help that, right? So those are the exciting areas. Now, when we talk about, I do want to talk a little about radiomics versus pathology, and then really finish up a little with surgical guidance. Now, when we talk, I did mention that we can predict certain molecular phenotypes, and I think that's realistic. As I've said in my other talks, we should not expect imaging to replace pathology. This is not realistic. I don't think that's the goal. But I think what we can do is AI is going to push the boundaries of imaging. In imaging, we have pretty much mastered anatomy. And now we're going to go, then we have gone into domains of function and molecular. And we're going to try to push that boundary. Just like pathology is going to use AI to push their boundaries. So the question is not to replace, but that we are each expanding our boundaries further to help patient care, to provide more personalized precision medicine. And there's certain advantages, when we talk about tumor heterogeneity. Now, pathology and let's say molecular analysis, of course, will always give you a layer of information you will not get through non-invasive means. At the same time, one of the advantages of imaging is when you biopsy, you can't go, unless you take out the whole tumor, which is no longer biopsy, right? You're getting a sample, and knowing that tumors are heterogeneous, naturally, you're not getting the whole thing. One of the advantages of imaging is in situ, while in the patient, you can analyze a whole lesion. And this is one thing that could be exciting, that if we can reliably implement this technology, you can actually follow patients in situ and look at the whole tumor, not just a part. More importantly, if you think there are a number of diseases also not treated surgically anymore. So again, you can actually fully analyze a lesion when you are not going to take the sample out. So I think this is where there'll be advantages. Of course, pathology and molecular analysis will always have the advantage of providing much more detailed information, but that is not a little thing. Now, if you take this concept and think of neurosurgical practice, you can see how this can be relevant. One is that I do foresee, but I'm curious to see what Dr. Del Maestro and other people think, is that traditionally, we used to confirm everything with biopsy. And by the way, sometimes you should do it. Even as a radiologist, I sometimes get frustrated when people avoid the biopsy when needed. But there are instances where we likely will not need biopsy. There are probably, by the way, instances where we don't even need biopsy now. Let's say someone has a known cancer, they get typical metastases. It's not clear to me. I think a lot of times people don't do it anymore. And I think with AI, we can push that boundary. So reduce some of those non-necessary invasive procedures and limit them. If you take it a layer further, using both just conventional good informatics infrastructure of adapting the information and then merging it with surgical guidance, there is no reason why in 5 to 10 years, we should not be using the information available on diagnostic scans better to help surgeons, to help them guide their biopsies, right? So if a tumor is heterogeneous and we can mathematically determine risk within different parts, of course, then you want to use that information. And I think that's a very realistic thing, is that it will guide you to a certain area because that's most likely to give you a good diagnostic yield, and let's give you the most representative grade of a tumor or the highest grade. And I think that is something that should be feasible and something we should strive for. And again, it's a nice merger of this continuum. And indeed, if going back on my things, I talked about imaging, but really these specialty classifications are important for the way we organize and train. But ultimately, this is all about the patient care pathway. So the MRI is as relevant to a neurosurgeon as anything, right? You use that to guide. So I think we even have to get out of that thinking, right? So we all work together towards a certain goal, and our roles evolve over time to give the optimal care. That's going to be the continuum of care and medicine. Now, before we open the floor for questions, I did want to think. So we talked a lot about direct image analysis, but you should know that there are related applications. Some of these are very radiological, but they will have impact on a practicing neurosurgeon. Let's say you do have, because there are more and more in radiology work list prioritization approaches. Let's say to alert us that something's urgent. By the way, that could be useful to you. Hey, you know something's gone wrong. This, there's a potential herniation syndrome. There's an active hydrocephalus. So there are practical. So we do all the fancy things, but do not overlook the practical things that can actually really impact patients by accelerating timely diagnosis. So these are things that are, I think, are interesting, even though there are a lot in radiology. And then the other question of multimodal integration. So now we have, this goes back alone to the precision medicine, is that we use all the information we have, all the sequences to do predictions, otherwise we wouldn't be able to make. But I would take that further. All the information means everything. That means things in the chart, blood tests, and these are important. Indeed, the idea of multidimensional biomarkers is something that really interests me. Ultimately, these are all data, and we want to help the patient. So we can look at them that way. Now, more data, of course, is good and is a curse. When you design an algorithm, usually your dimensionality reduction is actually the challenges. So these are things we have to, we have to be able to balance. But with sufficiently large data sets, ideally, you would not want to miss out on any of the data. And it is very likely that once we set up systems where you can do really thorough analysis of a patient's chart, put different things together, there's likely associations there we just would not think about, because we do certain things well and machines do certain other tasks well. That's why the combination could potentially be very effective in doing certain things. And this greater integration of multidimensional data obviously could be to predict a grade, maybe prevent unnecessary biopsy, guide your biopsy better in terms of AI-assisted precision surgical guidance, which, by the way, will likely be able to be incorporated into the robotic systems. So that actually works well. All of these things are coming together. But maybe you should even think of it one layer further. How about risk and outcome prediction? Who's likely to not do well after surgery? And yes, that may be characteristics of the tumor, but I would argue there are likely characteristics beyond that lie in the chart and in other imaging that right now we just are not analyzing. Let's take subcutaneous fat, right, as an indication of how cachectic someone is. There's no reason to think that these cannot be merged. Things that you wouldn't even want to look at, maybe there's a lung scan. If you can think, the algorithm might say, hey, there's a lot of emphysema. And who knows how these associations may able to risk stratify patients. Because one thing I do have, like my cousin's neurosurgeon actually started in neurosurgery. So I understand that mentality. And one thing I remember from one of the very early neurosurgeons I worked with as a medical student, who told me, Reza, the best, and that person used to do back surgery, and said, the good surgeons are the ones who know when not to operate, right? You want to operate on cases where that has benefit. And there's potentially a lot of data might not even be on your radar, not even the same organ system, that may have an impact. And I think these are really interesting horizons. And again, if you think multidisciplinary, we are not treating organs, we're treating patients, right? And so if we look at it more broadly, I personally think there's a lot of interest in that. And that could really change the way we manage our healthcare efficiency, outcome improvement. And again, I'll be, of course, interested to hear what Dr. Del Maestro and other members think of that. But let's think about this. This is not about imaging. This is about a lot of data that we are naturally underutilizing because it's too complex. There's too much information, and not always in the way that humans digest well. And this is where, again, the augmented part of the AI can be very useful. In imaging, one way I like to see us is, again, in terms of being more clinically relevant. Right now we tend to give measurements. The future report, probably volume would be standard, but volume is just the first step. I mean, the way I would like to see these is a probability, it's maybe some classification, probability of a certain molecular phenotype, probability of response to treatment. And in that sense, again, that's why I don't see this as a threat. I see this actually as increasing my role in the patient care value chain. And that's ultimately what people want, right? Why should it be a threat? I think that the different clinicians would like us to more accurately predict, or would like us to be able to help them say, oh yeah, this patient is not going to do well on the treatment. I can't imagine them not being excited about it. And if we look towards that this technology could be very interesting. It will move our boundaries in radiology more at, in terms of broader diagnostics, and have us be, help their treating physicians with their part as well, and integrating everything. There are a number of challenges. They're not little. As exciting as this is, there are real challenges. And in broad categories, these are technical variations and reproducibility. We've referred to that. Even the signal between the same scan across different sites. But I can tell you sometimes there are differences based on magnetic field strength, a range of things. These will have to be addressed. And by the way, these are not always sexy, but these are going to be the difference between experimental versus translation. Ultimately, I think my value will be more in the translation part, because otherwise, if there's someone who codes all the time, is going to do that better than our lab, right? So in that sense, one of our goals is to have this very multidisciplinary set of like machines learning experts in the hospital, but working with others to also try to help this part, which may not be always of interest to those in the more basic hemisphere sphere, because this is right on our radar, right? Data harmonization, don't underestimate that. Should be, for example, normalize. I don't even like normalize. Should be resample all data into one space. Very controversial. If you're doing handcrafted, probably yes. Probably everything has to be reconstructed in a certain thickness, because signal will change depending on thickness. Even a basic thing, if you imagine. With deep learning, it's a little more controversial, because theoretically, deep learning is very good at analyzing complex data sets. And if you have millions of data sets, you may not need that. But these are things that have to evolve with time, but have to be on our radar in order to do. And by the way, if you think even integrating a lab value, it's not that simple, because if you take multiple labs, even their range is not the same. This is something like seems so basic to us, but if you're trying to put numbers in a machine, you have to think at this level. Is how do we harmonize data is going to be one of the key things, especially if you want generalizable things that work across. So eventually you want a broad standard, both in terms of access, but also in terms of how data is processed, so that things can translate from one side to another. Large and varied data sets are key. In imaging, these tend to be mostly done on X-rays, but more and more will be done on cross-sectional imaging. I work with some industries, like I know I've seen experiments clearly showing that, let's say if you have an algorithm analyzing chest X-ray, once they include not only multiple sites, but data from multiple countries, those things tend to be much more reliable. You need that kind of variety. And remember, ultimately, if you're applying an algorithm to another site set, the basics of that place, the noise has to be represented in your data set. If it's not, you should not even expect to have a robust AI. It doesn't work that way, right? It's like, let's say if a neurosurgery resident has never done a certain type of procedure, they probably won't be good at it. So you can almost think of the algorithm in that sense. It has to be exposed to that in order to be able to analyze properly. Even as radiologists, when we look at different sites, sometimes if I cover a different site, I almost have to adapt a bit to a CT, the way a CT is or a different scanner is, and recalibrate what I call as normal or abnormal. White matter hypodensities. You'll be surprised. And we do this subconsciously, but the machines will have to do that. And the way they'll learn to do that is by being exposed to the sufficient variety. And of course, there's a whole field of data sharing, ethics, and privacy, the legal components, which are actually not to be underestimated. We need to have a way of securely share large data sets if we want to really see the potential of AI. As long as we can't do that, again, we just won't be able to create those robust algorithms that are generalizable. But the good thing is people are working on these different things. Of course, legal and regulatory, I won't get into here. And lastly, think about practicalities. For us, one of the things I'm hoping this year we'll see if we can get is we want to get an orchestrator with one of our industry partners, meaning that I want to have a system where we can analyze the image, feedback to PACS. It seems simple. This is not even interesting, right? But if you think, if you're going to do a clinical trial of some of these things, do they work in clinic? It has to be feasible. If you each have to go spend hours to analyze one image, doesn't matter how good that is, it won't work, right? It's people don't have the time. And we should not overlook these. But if we do focus on these, then I think we can start actually seeing how AI may work in real life. And some of this goes back to basics informatics infrastructure. So really in summary, we went through some image analysis, but I didn't stick to that. I hope you found the talk interesting and relevant to you. And I really look forward to the discussion and see what are the ideas here in terms of some of what I presented and how it might apply to you, to what you do. So thank you again for the invitation.